Hello and welcome back to the Her Drive Sovereign series. This is a very special series diving into the definition of sovereignty, what it means to have that taken away from you, or to advocate for it, or to really just embody it fully. This collection of guests are so special to me. I've followed many of them for many years. And today's guest, Jessica Pinn, little does she know, is not just an advocate for women's health and has been an activist for a long time for other women, but she personally impacted me in a way that prevented me from having a surgery that could have changed a lot for me. So I'm super grateful to have her here. Jessica is involved in a lot of things surrounding women's health. She's the founder of She Project Med and is definitely pushing for changing training standards around the vulva and procedures around I'm guessing surgical situations that we'll dive into. So, Jessica, thank you so much for being here. It's a huge honor, and I cannot wait to dive into your story and the very important, super significant work that you do. Thanks for being here.
Thanks so much for having me.
You're welcome. So, for those of you who have never seen your work or familiar with your profile, can we dive into a bit about who you are and what it is that you're doing?
Yeah, so I advocate for better coverage of clitoral anatomy in medical literature and curricula. So far, I have changed 15 major medical textbooks and two top anatomy apps, virtual dissection tables, anatomy posters, and board certification exams for plastic surgeons and maintenance of certification for OBGYNs. I also published a study of the dorsal nerves of the clitoris with my plastic surgeon father and a couple of his residents. And I got the first detailed illustrations of a cross section of a clitoris made. And I've just been trying to get that anatomy disseminated to all surgeons considered qualified to operate on vulvas because I had a bad experience when I was younger where I was harmed. And then I realized that surgeons were doing surgery on anatomy they didn't know. So I try to get that changed. And then I also try to change privileging. So, like how they give surgeons permissions to do different procedures at surgery centers and consent forms. I've gotten the American Society of Plastic Surgery to change their standardized consent forms. I've also gotten misinformation off of like major medical websites, like off of the ASPS websites, out of the previous ACOG committee opinion, off of, the Stanford plastic surgery website, and out of some textbooks.
Okay, I feel like this is just like punch after punch after punch of amazing work and a huge lift to do all of that for a part of the female anatomy that I feel like most people don't care about or only care about it for one thing, two things maybe.
Yeah. Um, I mean, I think the clitoris is super important and actually the vulva as a whole. Um, so, like if we were going to discuss it in terms of the homologous male anatomy, then what is homologous to the penis is actually the clitoris, clitoral hood, and labia minora all together. That's what's homologous to the penis. So, one thing that I've argued is that the clitoral hood is really the clitoris, it's the skin of the clitoris. And that's something that a lot of doctors don't fundamentally understand when they're operating on the clitoral hood. They don't think of themselves as operating on the clitoris. And even recently, I had a top female genital mutilation reconstructive surgeon say that usually it's not possible to damage the clitoris in a clitoral hood reduction. And that was just such a strange thing to say, in my opinion, because the clitoral hood is literally the skin of the clitoral body. So people often say that it's homologous to the foreskin in males, but it's actually homologous to the dorsal shaft skin. So like most of it is like shaft skin. And if you dissect it away, then you're basically skinning the clitoral body. So like if you remove the clitoral hood, what you're actually going to see is like a little shaft. Like that's what there. And so the clitoral hood is mostly the shaft skin of the clitoral body, and the nerves of the clitoris, they travel on top of the clitoral body. So that's like the main anatomy that I have focused on. But then also, I tend to think the labia minora are really important, and I actually think that they should be conceptualized as extensions of the clitoris. And I think that all this anatomy works together, like for female sexual function.
Okay. I I have a full understanding of where you're coming from based on following you for many years and what you've been sharing and advocating for. But I think the big question here is why would someone, why would a cis or whatever, like a born woman, I don't even know all the terminology now, so you can correct me, but if I'm born a woman, why would I need surgery on my vulva and my labia?
Well, I think most of the time surgery is not needed, but female genital cosmetic surgery has been pushed pretty aggressively. And surgeons will say that protruding labia minora, which are common to half the female population, are quote unquote hypertrophic. Hypertrophic means excessively developed. So they claim half the female population has excessively developed labia minora. They say that this is unfeminine and embarrassing and caused by aging, sexual activity, masturbation, and excess male hormones. There's no evidence for any of those claims, but that is what I saw when I was 17. So I thought there was something wrong with me. I think there are also a lot of other sources of women's insecurities about their vulvas, and that, you know, doctors have been incentivized to exploit that for profit, and they have. So that's like one thing that I focused on, but there are other surgeries that get done on vulvas as well. Um, one thing shocking is, they do clitoroplasties on girls who are born with large clitorises. So, like, they do these clitoral reduction surgeries on girls who are on average 23 months old. Yeah.
I had no idea.
And they'll say like it's needed because they have excess androgens, but really it's just cosmetic so that they look quote unquote normal. And it's like a feminizing surgery. And in the top OBGYN surgery textbook, it still recommended a technique that involved severing the nerve supply to the clitoral glands on purpose just because it's easier, as of 2015. So that didn't change until I emailed the textbook authors and editors and requested that it be changed.
Wow. So how simple was that? Just you sent a one email, or was it quite a procedure in order to get them to change it?
So I wouldn't say that I was particularly deliberate with my strategy. I used to just fire out emails to whoever's email I could find. So first I emailed the author of the anatomy chapter. I talked to him, and I talked to the author of the new anatomy chapter. I also tried emailing the editor, and for that textbook, and um, it's hard for me to keep track of who I emailed. I also posted on Medium, and yeah, so I would what I used to do is I would just try everything that I could think of.
Mhm.
So like I would just email, authors, try to get a response from someone,
Sure.
you know, point out the problems. I was mostly focused on getting the anatomy corrected,
Mhm.
but I also asked for, well, I think what I did is I linked to the review that I wrote,
Mhm.
and I said, all of these problems need to be fixed and it looks really bad. That the textbook is this bad. That they're saying, as of 2015, that, a woman is recovering from cancer when she starts to put on lipstick, and that women need their sexuality validated by friends, family, and strangers on the street. Things like that. They don't.
Well, this textbook had all of that within it in
Yeah,
2015.
yeah, it's and also But the most shocking thing is that it said a lack of clitoral sensation doesn't seem to affect patients' later sexual behavior after procedures that sever the dorsal nerves. And it said sexual function seems satisfactory. So, what was going on is, in general, like male OBGYNs were originally actually just amputating clitorises in girls with enlarged clitorises, but then they started wanting to preserve like a normal aesthetic appearance. Sorry. So at first, they were actually amputating the clitorises of girls with enlarged clitorises, and then they started wanting to preserve normal aesthetics. So they started doing more complicated clitoroplasties, but they wouldn't even try to spare the nerves because they said a lack of clitoral sensation doesn't seem to affect patients' later sexual behavior. So in this particular textbook, which is called Talen's Operative Gynecology, they go over two techniques, and one is supposed to be nerve sparing and the other one isn't. And they recommend the non nerve sparing one first. And then after they recommend the nerve sparing one, they say again, this doesn't seem to matter.
Wow.
But the nerve sparing one actually said like it didn't indicate knowledge of where the nerves were. Like I think it actually was not nerve sparing. It
Mm,
was an attempt to be.
I see.
Basically, the literature is really bad, and um, that's just an example of one surgery. Also, vulvectomies, so surgeries for vulvar cancer. A lot of vulvar cancer patients have been treated like their sexual function doesn't matter because, what all that matters is that they don't die and they're not really treated the same, I don't think, as men who have penile cancer. Um, they used to be really aggressive with vulvectomies. In more recent years, they have tried to, save the clitoris. But in the vulvar cancer literature, it says things like that, make sure you try to avoid removing the clitoris if the woman is younger than a certain age. Like as if you didn't really need to worry about it if a woman is old, which I think is pretty awful, and sort of male centric. And also, they say in multiple places, like in multiple textbooks, that the extent of vulva removed, the amount of vulva removed, is not correlated with sexual dysfunction after vulvectomy. And that actually comes from a really poorly done study that concluded that how much of a woman's it comes from a really horrible study that concluded that how much of a woman's vulva you removed is not correlated with how much sexual dysfunction she has after vulvectomy, which is just obviously wrong. And it comes from them asking the wrong questions in order to measure sexual function. And it also comes from the fact that in the sample, only two of the women had had clitorectomies. So there was a very small sample of women who had had their clitorises removed in the vulvectomy. So then there was it basically they weren't really measuring it right, and then the conclusions that they were coming up with and printing, they have pretty dangerous implications for patients, if doctors really think that, which hopefully they don't. But I mean, there's just crazy stuff out there. Anyway, so yeah, vulvectomy, and then also vulva repairs, like um, vulvas can get damaged in childbirth, they can get damaged from accidents. It's sort of weird when medicine acts like vulvas are invincible and repairing vulvas is not something that ever needs to be worried about when we, literally deliver a giant baby through through that area. And also, we can fall and hurt things. We can hurt things in that area just like any other.
Yeah. So what's your thought on why there has been, and I guess still is, misinformation and lack of proper studying of that part of a female's anatomy?
Because it's considered not reproductive. So female sexual pleasure has been considered separate from reproduction. and not relevant to reproductive health, which I strongly disagree with. So I really object to people who say that the only role of the clitoris is pleasure, because I do think it has a reproductive role, and I think assigning it no reproductive role has caused it to get treated as if it's not important. Um, After I was harmed, I was told my sex life wasn't my OBGYN's business. I was told by OBGYNs that they weren't concerned with the clitoris or with female sexual pleasure because they were focused on reproductive health. Like, that's the argument. The argument is they're not concerned with sexual pleasure. Maybe specialists can focus on that. I actually had female OBGYNs argue they shouldn't have to know clitoral anatomy because it was not relevant to their practice.
I feel like it scrambles my brain to hear that is a place where someone who seems to be value understanding the body and processes and functionality would reach that point and that belief system. Um, that sounds, yeah, that just sounds incorrect to me. Someone who does not work in the medical industry. So when you say that you were harmed, like, what's your story that obviously seems to be it shook you in such a way and really impacted you that this would be the work that you're doing?
Yeah, so I saw a labiaplasty when I was barely 18. Actually, I saw it when I was 17. My surgery was within days of my 18th birthday. What happened was I had gotten online to find out what a clitoris was. I did not know what a clitoris was, which is pretty embarrassing because I was 17 years old. I didn't know what that meant. So I got online and I learned the word vulva for the first time. I learned the term labia minora for the first time. I had never been taught any word other than vagina, which is crazy. And so I was looking into information about those parts because I was pretty confused. One thing that happened was I could not relate to the illustrations that I saw, because like I was straddled in front of the mirror looking at myself, looking at the diagrams and thinking, gosh, that's definitely not what I'm looking at, And I still have a pretty big problem with most medical illustrations to this day. They tend to exaggerate the vagina. They tend to minimize the clitoris. They're very stylistic. So if you don't already have a good idea of what's going on, I think they're pretty hard to learn from and relate to. And there's actually an interview study that found that, quite a few women felt that way about medical illustrations, about anatomy illustrations, like they couldn't relate to them well enough to really understand. Um, so that happened. And so then I was Googling photos and I think at one point I must have Googled, are my labia minora normal? Or
Yeah.
just or just like labia minora, because I do remember, I went to the Wikipedia page for vulva, and the illustration on the Wikipedia page for vulva had very, very small labia minora at that time.
Mm-hmm.
What I now know is that that vulva was actually very unusual. But that was like the standard shown on Wikipedia. So I thought that I was supposed to look like that, or I didn't really know. So I Googled, and that's how I got, plastic surgeons' websites
Mm-hmm.
telling me that I have unfeminine and embarrassing labia minora, that they are caused by excess androgens, aging, sexual activity, and masturbation. What's really funny is when I was 17, I was scared of anyone finding out that I had ever masturbated. I was like really ashamed. I didn't want anyone to think that I masturbated. You know what I mean? So I was mortified. That was like a major thing that bothered me. And then also the idea that it was caused by excess androgens, like excess male hormones, and it was called hypertrophy because hypertrophy sounds like a pathology. It sounds like a disease.
Yep.
So I thought that I was basically deformed. Um, so I, yeah. So then I wanted a labiaplasty, and I had one. It was performed by an OBGYN who was recommended as the best OBGYN surgeon at the hospital where my father works, and my dad's a plastic surgeon. He asked around at the time, and other doctors told him it was no big deal that people do labiaplasties all the time. Um, my doctor is really highly respected. He was president of the Texas Medical Association, president of the Dallas County Medical Society. He's been in Time magazine. You know, he's not just anybody.
Mhm.
And he was introduced as a doctor's doctor in an award ceremony. So he is the doctor that you are supposed to be able to trust to operate on your family. And what he did is he completely amputated my labia minora. He performed a clitoral hood reduction without my consent. And he basically amputated the clitoral frenulum as well. So, so I have very distorted anatomy,
Mm.
and I lost clitoral sensation. And after the fact, I I didn't really understand what had gone wrong. I blamed myself. And when I did bring it up, which was really, really hard, I remember when I first brought it up to his partner, who I saw after him because I didn't feel comfortable with him because he was an old man. Um, I was shaking when I tried to ask her, when I tried to ask if my surgery had caused me to lose sensation and was making it so that I couldn't orgasm. Like, I was actually shaking because it was so hard for me to talk about.
Mm.
And she told me, no, that wasn't possible. And she told me that I looked normal. So I knew that was wrong. So then I went to a different doctor after that. And she also told me that it could not have affected my sexual function and that I just needed to relax and that I just needed to fall in love. Actually, no, she told me I just needed to fall in love. The previous woman told me I just needed to relax.
Mm.
Um, so that was when I started to catch on that they didn't know what they were talking about.
Mhm.
So I did my own research. I taught myself anatomy. I figured out that a clitoral head reduction had been done without my consent. I taught myself the course of the dorsal nerves of the clitoris. I realized that OBGYNs were not learning very much about the vulva in general. You know, like when I asked what my labia minora were for before my surgery, my doctor shrugged. I spent a lot of time trying to figure out if there were any risks. I
Mm.
even read at least one peer reviewed outcome study that said no risks and no serious complications. The main up to date article still says no serious risks or complications. It still does not mention any risk to sexual function. It does not mention any function of the labia minora. It says there's a high satisfaction rate. It doesn't discuss that there can be any like long term damage.
Wow.
And that's on up to date, which is supposed to be up to date.
Yeah.
And on top of that, this is in the up to date article that I got them to change. So, so like I got them to add that surgeons need to be careful to avoid actually the clitoral hood, frenulum, and the innervation of that area, which is pretty good. And I agree that, like, I personally don't think clitoral hood reduction should be done. So I appreciate that they said that. However, the labia minora are also functional anatomy. So it's weird that they don't acknowledge any risk to reducing them. On top of that, they show a technique that is exactly the one that my doctor used.
Oh no.
And so basically, they show a 15-year-old with her labia minora stretched. And they say, oh, this is how you measure the real length. So then they're stretching them and marking them while they're stretched, which is how they end up removing too much because a lot of times they have a poor understanding of where like the transition is between the vestibule and the labia minora, because if you just stretch it out, you it's like harder to see, and then they mark it, and um the ends can like shrink up, so then you end up with nothing.
Oh my gosh, that's so stressful.
Yeah,
Uh-huh.
and it's still like they're still not teaching this in a reasonable way. I have gotten a lot of resources changed though, so I'm glad about that.
Absolutely. So I can understand why you've turned your attention in such a profound way. What were you wanting to do with your life before you had this surgery?
Um, well, I was in high school.
Right. But I mean, like, I feel like in high school, we're even like, well, I'd like to do this or that.
I actually didn't really know what I wanted to do in high school. I thought I probably wanted to be a doctor, but my dad was trying to discourage me from becoming a doctor.
Okay.
Um, I did biomedical engineering in college. So I was pre-med in biomedical engineering and I really enjoyed that. And I minored in electrical engineering, but I never really knew what I was doing. I was, struggling with PTSD and depression the whole time. So that was hard. And also, the honest truth is I had had some issues in high school with depression. So I had never looked that far into the future. And there were a lot of people that, even though I was very smart and I had really good test scores, there were people who questioned my ability to succeed. I don't want to get too much into that, but there were just some things that happened that caused me to like not necessarily believe in myself enough to want to set long-term goals, which is kind of sad. Um, but I picked biomedical engineering because I knew that I was at least taking the next step. But it was funny because in my technical writing class at WashU in St. Louis, they asked why I chose biomedical engineering. And I said, well, it's sort of like when I was little and I needed to pick a favorite color. And I didn't really have a favorite color, but I just needed to give the adults an answer. You know what I mean?
That's hilarious.
So I kind of picked biomedical engineering because I had to pick. And I didn't really have any confidence about it. But what's interesting is if I could go back, the only thing that I might do instead would be computer science. So my decision was actually pretty optimized because biomedical engineering made a lot of sense for me as far as my interests and because I love math. So
Okay. Interesting. Interesting. I find it fascinating that, I mean, here you are going into uh, medical engineering, and now you're the one who is looking at all these different diagrams, drawings, illustrations, etc., and language that's used in procedures, and actually correcting medical programming for people who are meant to know these things through their training. And so, if you could go back in time and give a younger you some words of wisdom, what age would you be, and what would you say?
that's really hard because there are a bunch of times that I could go back to and completely change the course of my life. So obviously, I would go back to 17-year-old me and I would say, do not have a labiaplasty. Or I would go back even to younger than that and say, just be happy with yourself the way you are naturally. Don't try to fix things. Don't look for things wrong with yourself to fix to be more beautiful. So, like, I used to think I had to straighten my hair and I had to like wax the hair on my arms. And it's led to some conflicts with my mother. And I wish I could go back and just tell myself that I was okay and I didn't need to be so concerned with my appearance or with trying to like fix it and make it better all the time. Because I think that mindset made me vulnerable to the surgeon saying that I was ugly. Because I think some people maybe are able to just be like, well, I'm ugly, who cares? But for me, I felt like it was something that needed to be changed immediately and like it was a crisis.
Yeah, for sure. Well, I find it interesting that in your story, it seems like your rearing and like activities were a little bit different than mine. Like, if I can bring my personal story into this, I grew up in like a small town, whatever, but what like lost my virginity at 14, was like very sexually active, was like totally okay with masturbating and like very in my feminine feels. And I didn't really think about the anatomy of my vulva or anything in my pants region until later. And then I started hearing boys talk about like B flaps and like other really derogatory descriptors for women's anatomy. So it wasn't until much later I had an ex partner who had said some kind of mean things to me, that I was like, oh, I guess I should get a labiaplasty. And I was very seriously looking into it. I'd found different surgeons to talk to. And it was actually you who I heard you on another podcast. This was quite a few years ago. And you changed my mind. Like 100%, like normalized my body, normalized the function, and made me to go into a deeper dive of actually accepting myself and dismantling, patriarchal norms and marketing terminology used to make me feel like I was lesser than, and to embrace myself. And I use like vulva mapping and other processes to look at my body and to like really appreciate it. So I thank you very much for existing, because you changed the trajectory of my love for myself, and I appreciate it so much.
I'm really glad for that.
Yeah,
Wait,
yeah.
how old are you? Are you younger than me, I guess?
Uh, I'm 34.
Okay, I'm 37.
Mhm.
I feel like I also grew up in Dallas, Texas. Where did you grow up?
In Ohio, and I live in Dallas right now.
Okay, small world. So
Yeah.
I feel like I grew up sort of conservative. Um, I I guess I missed ninth grade sex ed, so I only had sex ed in fifth grade, and I just didn't learn anything apparently about the vulva. And I also, it's a long story, but I went to this weird boarding school in Montana where they told us that masturbating was acting out a sex addiction. So there was that. I think that I picked up negative messaging about being sexual as a woman from a few different places. And so I just sort of like absorbed it and didn't want anyone to think that I was a slut or masturbated or anything like that. I was a virgin still at the time of my surgery. I was 18. And I actually think that that made me more vulnerable because I suspected that the labia minora played a role in sexual function, but then I just believed the authorities when they said that they didn't. Even though I was confused, I sort of like discounted my own feelings about my own body, which is weird because I think I didn't have enough experience really, and I didn't have enough awareness.
Sure. I mean, you also think about your age. There's a lot of diminishing going on due to age, and they're professionals. And why would they lie to you? This is what they're supposed to be an expert in. So I'm sorry that that occurred to you. And I'm curious. After the surgery, you said you had PTSD. So, what are some ways that you've worked through this just in your own life? And you said you blamed yourself. How did you process that out?
Um, well, originally I blamed myself,
Yeah.
and then I dug into the medical literature and I realized that what happened to me happened because of systemic negligence, because surgeons were doing surgeries they had not been trained to do on anatomy. They didn't know. Um, I realized when I watched porn for the first time, I realized I had been lied to about, what was normal and considered attractive, right? Because I had surgery thinking that I had some kind of deformity, and then I got on like Pornhub or something, and I saw a lot of porn stars had, sorry. So I thought that I had gotten surgery because I had some sort of deformity. And then I got online and I saw porn, and I actually saw a lot of women who looked like me before my surgery. So I figured out that I had basically been lied to. I had been misled. And so then I blamed myself a lot less. I also realized that my result was not normal at all. So once I understood that like my result looked mutilated compared to any natural aesthetic, then I really realized it wasn't my fault because my doctor shouldn't have done that to me.
Mhm.
I think as a surgeon's daughter, I assumed that a bad result was just bad luck, like something unforeseen, unpreventable. But then I figured out over time that what happened to me was extremely predictable and preventable with basic education and training standards.
Mm. Whew, that's a tough one.
Yeah, so then that actually caused things to be more traumatic for me. So it was actually easier when I blamed myself.
Interesting. And why was it more difficult for you?
Um, because then I saw the entire medical community was going along with this systemic negligence.
Mhm.
And the way I felt was like I had been treated like my sexual function didn't matter. And like I was just sort of acceptable collateral damage in their pursuit of profit. Like that this really important thing that was taken from me, I was treated like that didn't matter at all. And I think it's sort of hard to explain, but when like I think when you experience like an interpersonal trauma where someone else is able to hurt you really badly and there's no justice or anything and you're treated like it's not supposed to matter at all, it can make you feel sort of worthless and also just not in control of anything that's going on, you know?
Yeah.
So I think that was very distressing. I also had a really strong need to try to change it. I had a strong need for some sort of justice, first of all, and then I had a strong need to, solve the problem to protect other people because I was just so upset that it happens, right? Like I was so upset that no one had made sure that these surgeons knew what they were doing before they operated on me or anybody else.
Are there other areas of the body that are operated on that surgeons shouldn't be doing because they don't have proper understanding and procedures in place?
Not like this. I have tried to figure that out. I mean, I hate to bring it up. I think maybe the closest thing is circumcision, but the foreskin is only equivalent to the free end of the clitoral hood, so it's really not comparable to disregarding the entire vulva, disregarding clitoral anatomy entirely. Um, Otherwise, I really don't think so. One thing that I did was I compared the literature on female genital cosmetic surgery to the literature on rhinoplasty and breast reduction. It is very, very different. I compared the literature on female sexual function to the literature on male sexual function. So, with the literature on female versus male sexual function, with male sexual function, they address it like, okay, this is how a penis works. This is what could be wrong if it's not working. And they go over the anatomy and physiology in detail. They have tests to figure out what's wrong. With women, they say women are emotional and complicated, and orgasm may not be necessary for satisfaction in women. They say women are hard to study. They say, oh, it's complex, and then they neglect any like scientific inquiry into what's going on. Like that's the pattern.
Oh my goodness.
So, um, and some people might object to that, but in the big picture, if you look at the literature on female sexual function and dysfunction in OBGYN literature, primarily it means the ability to be penetrated without pain, and it means psychological satisfaction instead of any sort of concrete physiological process. And I came to that conclusion actually from analyzing the context of every mention of sexual function in the top two highest impact factor OBGYN journals. So I like went through and I looked at every single mention, and that's what it usually means. I don't think I did not actually find a single mention between the years of 2000 and 2012 where sexual function in an OBGYN journal referred to physiologic function like in a concrete way, which is crazy. I
That's
think I could say that I was wrong, but like I made a graph. Um, I used to just what I did was I dug deep into medical literature and I analyzed everything that had contributed to what I went through. So I compared male and female
Mhm.
sexual function literature, and I also compared literature for different surgeries. And with vulvar cosmetic surgery, shockingly, they go over techniques without ever discussing surgical anatomy. So they only cover the surface anatomy, and then they cover this is what you cut.
Wow.
They cover anatomy better for the outer ear. So like nobody's so it's crazy. Nobody's pinning ears back without learning anatomy first, but they are cutting off pieces of the vulva.
I mean, do they just think it's like skin with nothing in it?
Yeah, that's how they treat it.
Okay.
And yeah, it's weird because even if they don't, like even if they recognize, oh, there are nerve endings,
Yeah.
they don't like if you look at the literature, they're just like, this is where you cut and patients are satisfied. They don't really so notes about nerves you want to avoid or avoiding the frenulum are pretty new.
Mhm.
The dorsal nerves of the clitoris were nowhere mentioned in literature on female genital cosmetic surgery until I think 2015. The first mention was by Christine Hamori.
Mhm.
She bizarrely only brought it up in the context of saying that the risk of dyspareunia was low. So she was saying the risk of pain with sex was low. She
Wow.
didn't mention any risk of loss of pleasure, which is strange because she was talking about the risk of damaging the dorsal nerves.
Mhm.
And obviously, if you damage a sensory nerve, yeah, there's some risk of pain,
Mhm.
but it also means you lose pleasure.
Mhm.
She didn't mention that. So again, it's all about like ability to be penetrated without pain.
Sure.
And that was the first mention. Good on her for at least acknowledging that there are nerves there.
Right. Right.
Because the other surgeons were cutting into the clitoral hood without mentioning the nerves at all, without saying, oh, you need to stay superficial to avoid damaging them.
Mhm.
That was not mentioned.
So if you could like distill all of this down, what's the number one motivator for eliminating that as part of the conversation?
What do you mean? Sorry.
So if you could distill all of that down as far as like the reasoning why, all the reasons why no one would mention or it's not mentioned to stay, surface, don't go deep. Is it just
It's
financial
because
benefit or just ignorance?
it's because female sexual pleasure has not been considered medically relevant.
Okay.
And it's because of sexual double standards, preventing much scientific inquiry into the anatomy and physiology of female sexual response.
Mm-hmm.
So, when I was dissecting the dorsal nerves of the clitoris with my father, we measured them.
Mm-hmm.
And at the point where one other surgeon in particular had stopped dissecting and a study of the branches of the pudendal nerve that she published and sent to me, they were 3.6 millimeters in diameter.
Mm-hmm.
Or they were, so we measured them like where we first located them as they come around the crura of the clitoris. And then we measured them again at the angle. So that's where the clitoral body bends.
Mm-hmm.
And they were 3.2 millimeters in diameter at that point. So basically, where most surgeons have been stopping dissection is around where they enter the clitoris, at which point they're probably about 3.4 millimeters in diameter. We didn't actually measure them at that exact point. So, point is, over 3 millimeters, that's not hard to find, that's not hard to dissect.
Mm-hmm.
So, how did she just stop dissecting? Her answer to me had been the problem is that those nerves get very thin and difficult to dissect, unlike the nerves in the penis. She said they were difficult to dissect even with magnification glasses. So that was very confusing because I saw 12 specimens get dissected. I dissected two myself and I did not have any trouble. So, how did this woman, who is like the expert on female pelvic medicine and reconstructive surgery, think that it was too difficult?
Mm-hmm.
It's very illogical. I mean, one thing that I've had to come to terms with is that people are not logical.
Mm-hmm.
So what my dad said is people feel awkward.
Mm.
So that's what it comes down to. Is I think they just feel awkward. They don't want to keep dissecting because they're uncomfortable.
Interesting.
I also think that, I mean, I will say that in my study, the one specimen that didn't get dissected as far out as the others was the one that was dissected when I was not there.
Mm.
So I think also I was really, really invested in like mapping this very well and making sure that we dissected them as much as possible
Mhm.
because I really care.
Yeah.
And so I think that sometimes it's just a matter of people's incentives. And, like I wanted to make sure that we dissected them as far out as possible and that surgeons would understand just how far out they go and their vulnerability to damage because I was harmed. So sometimes I think that people are less interested because they're less personally affected, they're less personally invested for whatever reason.
Mhm.
But then also because they're just not comfortable. Because it's really hard to explain why women aren't more interested in like how they have orgasms and sexual pleasure and all of that.
Mhm.
It's really weird. And I expected women to care more
Mhm.
and I mean, it was upsetting when I realized, the first time I tried to talk about it actually was in 2011 to the doctor who had told me that I just needed to fall in love. I explained to her the anatomy and I said, please don't tell patients that in the future,
Mhm.
right? Because there could be like a real physical issue.
Yeah, absolutely.
And she got mad at me and kicked me out of her office. There were a few other things that I said, like I said, please tell patients they can report. And she said that was none of her business. And I said, according to the AMA's code of ethics, it is.
Mhm.
So I
Mhm.
think that, but it was really weird because I thought she would be interested in being a better doctor in case she encountered anyone else like me. Instead, she got offended and kicked me out of her office.
Ugh, that's a lot of ego and pride being wounded for sure. Man, and I also applaud young you, 18 years old, a lot of audacity and bravery to step into that space and advocate for yourself and for others.
Well, I didn't at 18.
Oh, okay, okay.
I mean, the first time that I tried actually was when I was 23.
Okay, that's still pretty young.
And it took me a long time to like be able to talk about it in person. It took me longer to like post online. The first time I tried talking to some medical students was in 2013 when I was 26 and I went home crying.
Oh no.
And I didn't know how I was ever going to do it because I felt ashamed.
Mhm.
And what's really sad is that when I was explaining, these guys were like, "Oh yeah, you're right." But then they said, "It's like how my girlfriend doesn't ask for what she wants in bed." And I was very frustrated because because it was like literally y'all are in medical school and you're not getting taught anatomy and now you're gonna bring up your girlfriend not asking for what she wants in bed. And I actually but what's really sad is at the time I just felt really uncomfortable that they made the conversation about sex when I was trying to talk about anatomy and I was trying to be serious.
Yeah.
And so I think fundamentally when I was younger, I was really afraid to talk about sex. I was afraid to be seen as the type of woman who talks about sex. Like I was afraid because of sexual double standards, because of slut shaming.
Yeah.
It was really sad.
Mm.
And I hadn't thought it through
Mhm.
as far as like that's a total double standard that I felt ashamed that the guys brought up sex when I was talking about anatomy of the clitoris. You know, they uh, they
Exactly, they did it. I think that speaks a lot to the society of which we reside within, and I'm really curious, um, what was the final push where you decided to be public about this, and also to bring it online where it's a much bigger town hall to reach more, but also to receive a lot more criticism and confusion from from the masses?
So for a long time, I knew what I needed to change. In 2011, I wrote a whole list of everything that needed to be changed.
Mhm.
I also, in 2011 and 2012, I wrote 200 pages analyzing everything that was wrong. And part of the problem was I only got halfway through my outline. And then my ex, who was in medical school, said he would read it, took months to read it. By the time he was done reading it, I did not want to work on it anymore.
Mhm.
I was taking a break from my paper,
Mhm.
coming up with excuses to not work on it. And the reason why was because my paper was so painful to work on. It was so painful, you know, analyzing medical literature, analyzing the negligence that led to what happened to me, and just having to be confronted over and over with the blatant disregard for female sexual pleasure, and just how preventable what happened to me was. So that was very painful. So then I didn't want to go back to it. Also, I didn't have a plan for it. I didn't know what I was doing with my paper,
Mhm.
and I didn't know what I was doing with my life. And I part of the problem was I got increasingly depressed. I was just having a hard time with depression and my self-esteem. At one point I was suicidal. So I just went through a lot in my 20s. And then I think an important thing that happened is I moved to San Francisco. And I think that for the first time in San Francisco, I was able to tell people about my advocacy in a way that was like, people were like, oh, that makes sense. I mean, I started talking about it in a very vague way,
Mhm.
but then I got some of the validation that what I was trying to do sounded important.
Mhm.
And I got it from entrepreneurs.
Mhm.
So in San Francisco, there are a lot of people who care about changing the world.
Mhm.
So if you say, oh, I'm analyzing systemic negligence in medicine, I'm trying to change training standards and guidelines and privileging, and I didn't explain any details, but just saying that I was working on that, even though at that time I really wasn't doing anything. But I had but that was like my plan. And so then when I explained that to other people, and I got this feedback that, oh, yeah, that makes sense. Then it made me less afraid. And then also I met people who had taken really big risks.
Mhm.
Um, and I also realized that I was just coming up with every excuse to not work on my paper because I didn't want to work on my paper. And I was never going to finish my paper. So then I had to move to the next step. So basically, I was stuck on a step. And I needed to realize I didn't need to do that step. I could do a different step. And it's a little bit silly, but so then I just went ahead and I met with the head of patient safety at Baylor, which originally I was supposed to do in 2011. So in 2011, I'd gotten the head of patient safety at the hospital where my original doctor works. I got him to agree to meet with me, but then I got afraid because back then I would get really triggered if people said, "Oh, there's no problem," or
Mhm.
anything like that. I would get really triggered, and I also didn't trust myself. Like, I felt out of control of my emotional responses.
Mhm.
So it was like I got to where I mean, this is like a trauma thing, like, people just start avoiding triggers. The next thing you know, you feel like you're, like, constrained to, like, this small space, and you can, like, hardly it becomes hard to do things because 'cause you're, like, just trying to avoid
Mhm.
pain. Um, so I think what happened was I guess I just got to a better place where I was no longer afraid. But I do think that meeting people who are trying to change the world and meeting people who took risks,
Mhm.
I think that that helped me a lot. And I also think that um, realizing that it was okay to fail helped me. Like that I could fail and then I could try again.
Mhm.
It would be okay. And I could try again. And I wouldn't have to stop if I failed the first time. That was something that I had to realize, but it sounds like it's so obvious. It's like everybody else grows up thinking at first if at first you don't succeed, try again. I was raised on if at first you don't succeed, you suck, quit.
Oh, shoot. Oh.
What it is it's a fixed mindset. There's this book called Mindset by Carol Dweck. It talks about having a growth mindset where, like, if you fail, you don't take it personally, you just figure out how to do better.
Brilliant. I'm so glad that you relocated, had those positive interactions, and grew in your self belief and continue to move forward. For women who are considering having any of these surgeries, what are your words of advice for them?
Um, so my issue is, most of the time people won't get harmed. They won't lose any sensation. They'll be fine. Or they won't lose anything noticeable, I guess, or significant. Um, my issue is that if you're paying these surgeons, you are incentivizing them to continue practice as is, to continue business as is. And right now, that business is misinforming to market surgeries. It is, you know, doing surgeries they're not trained to do on anatomy they don't know, or, surgeries that they haven't been reasonably trained to do. So, like, there are surgeons who offer training, but it's not standardized. And this is improving. Like, I've been advocating for example, like CME for labiaplasty. Um, like, I've tried to get residency programs to cover it because if their graduates are going to be doing it when they graduate, they need to be trained. Um, at the same time, there has been so much negligence that I think it's like buying clothes from a company that uses slave labor. Like, maybe don't do that, because if you do that, you're voting with your dollars that their business practices are okay. And in this case, the business practices are treating vulvas and female sexual function like it doesn't matter. Um, they are misinforming women and thinking that's okay. They think it's, well, they're using their medical authority to spread stigmatizing misinformation. And it's not really that intentional. At the same time, the, okay, like, reasonably smart people can figure out how to check references, right?
Mm.
So if people are spreading false information without ever stopping to check if there's any evidence, it's willful blindness. Like, they are spreading claims that they want to believe, that are convenient to believe, and there isn't any effort to figure out if they're true or not.
Mm, fair enough. Oh, so looking forward to the future, what are some things that you are um, most fired up about and seeking to make the most change in?
Um, I don't know. That's hard. I guess so. I have this nonprofit now, Sexual Health Equity Project, and I don't really know how it's going to go, and I'm not that confident about it. But one thing that I really want to do is I want to get our own medical illustrations made, our own 3D medical models made. I would like to somehow be involved in more research to get better measurements of the clitoris, because pretty much all mid sagittal plane illustrations of the female pelvis are wrong. And that's a bit ridiculous. So I've spent all this time focusing on getting doctors to know where nerves are, but all the diagrams, they don't even show, like, the size, shape, and orientation of the clitoris correctly. Like, it's basic shape. And I have realized that a lot of doctors are even more ignorant than I thought they were, which says a lot. Um, so it would be nice if we could get our own educational materials created, because even when I get resources to update, they're all still incorrect. And I might be nitpicky. So I'm really grateful for everyone who has made changes. I'm really happy about the updates that have happened. However, in an ideal world, we would just have correct illustrations of female anatomy. It wouldn't be so difficult. So I would like to get our own materials made. And so I think that that's exciting. Um, but really, I actually think what interests me most at this point in my life is trying to figure out how to change the incentive systems in medicine so that this sort of thing can't happen, because that's what's really bizarre. So you asked earlier if there was anything else like this where there's anatomy that doctors are operating on that they don't know. And I said no. But the truth is, I don't really know. And I know that there is potential for systemic negligence to persist in medicine with no incentive to correct it. So, on one hand, there are all these taboos that prevent people from being curious about the clitoris and being curious about female sexual function in a reasonable way. Um, but also, there there's like a lack of financial incentive and a lack of legal incentive for the medical organizations to improve standards, for the textbook authors to improve their content. They're just not motivated. And that's been really interesting to see. The one update that I got made that is the best, that is really good, was Theme's 3-volume atlas. And that's because I got to the vice president of Theme International. So I got to a business person. But what's interesting is that the people that, the way that it's designed is with the expectation that the people who are, authoring the chapters are editing the textbooks, that they can be trusted to ensure quality of information. What's really interesting is that a lot of them don't even seem to care, or they care about like selling the books, they care about their names being on the books. And some people might get offended by me saying this, but I promise, like, they don't care that much about making sure that it's correct. And like with some of these textbooks, they made a deliberate choice to not correct things because it's cheaper to not have to get new illustrations made. Um, and so that's, frustrating. Um, but yeah, and there was one plastic surgeon who didn't even know what was in her own chapter of a textbook. And the reason she didn't know is because she didn't write it. Because sometimes they'll get residents to write it, and then the residents aren't, I mean, it's not even in their name. So there are just a lot of weird incentives. So I actually suspect that a lot of medical errors are caused by systemic problems that no one wants to look at. Because what's gone on here is once I started bringing it to people's attention, there was a lot of denial, and it's been this insanely slow process. And I've encountered, a lot of doctors who, even if they acknowledge the problem, they don't want to speak up about it. They don't want to be seen criticizing their colleagues. And yet there are just like a lack of incentive systems that would motivate change. And I think that's like a really fundamental problem that impacts medicine broadly. And then also, I think that there's an information quality problem as far as like how these people aren't incentivized to ensure that they are publishing quality information. And that applies even to committee opinions published by professional medical organizations that we trust to represent our interests as patients. So that's weird. And the reason they don't represent our interests very well is because they have no legal or financial incentive to do so. They represent their members, like this professional medical societies represent their members because that's who pays them. The specialty boards represent the interests of the doctors they certify because that's who pays them. They can't get sued. It's really weird. Like, it's weird that it works as well as it does. In my
Yeah, it seems like a quite a fortified industry. Mm.
Yeah, so I think at this stage of my life, I'm more interested in how to change that. Like that was sort of the story that I told business schools last year, um, because I was trying to go to business school, and I don't know if you know what happened, but I got $100,000 Dean scholarship to Yale.
Mhm.
Then it got rescinded. Um,
I know this. Why was it rescinded?
they said disrespectful comments in the Slack and my social media. I think it was probably my social media. I think probably somebody complained, you know.
Okay.
I think that it was somewhat predictable,
Mhm.
um, because I know that I've been a controversial person on the internet. I know that I've been canceled. After I got in, my dad said, "Don't post about it online."
Mm.
So, in a way, I may have sabotaged a little. Like, I think I was pretty scared to go to
Mm.
Yale
Oh, you
because
think that you self-sabotaged?
a little, like, I maybe a little. Like, some of my friends have thought that I did because I love San Francisco
Ah,
and I'm really happy here, and I was a little bit scared to move to New Haven.
sure.
It's sort of the middle of nowhere in Connecticut, and I right after I got in, I went up to my uncle's funeral and found out that he dropped out of Yale because he got depressed there.
Oh, no.
So, that
Oh, no.
was a little bit scary. But so when I was applying to business school, I had this idea that, it might be possible to build for profit, some kind of for profit business
Sure.
that would somehow like provide. I mean, I had a bunch of ideas, but it's been really hard to figure out
Mhm.
what to do. But I do think that like there's a bigger problem than just this one particular thing.
Mhm.
And I'm sort of bored with the one particular thing.
Mhm.
So like basically there are like two causal vectors
Mhm.
that cause the systemic negligence is like one is like the cultural suppression of female sexuality and sexual double standards. But then the other is a problem with incentive systems in medicine. And there have been some other examples of that. Like one that I know that's a bit old is that it took over 25 years for the first professional medical organization to say that doctors should stop doing uh, prenatal X-rays.
Mm.
Wait, is that? Oh no, I'm sorry. Is it prenatal X-rays? I'm sorry. Um, do you call it a? Okay, I'm sorry. Anyway, so another example of this problem is that it took over 25 years for the first professional medical organization to say that doctors should stop giving x-rays during pregnancy after they proved that it doubled the risk of childhood cancer. Um, so I do think that there are things about the culture in medicine and the way that medicine is organized that make it very, very difficult to change.
Mhm.
Eric Topol talks about this in The Patient Will See You Now, which used to be one of my favorite books.
Mhm.
But Eric Topol is the chief editor of Medscape, and Medscape had 57 times as much information on the clitoris. I had them at least add clitoral anatomy to their article on female genital and cosmetic surgery when they go over the relevant surgical anatomy. They now have clitoral anatomy because they're operating in that article or they're describing surgical techniques. So now the ratio may be like 55 to 1 because they still do not discuss any detail for the clitoris in any of their articles on anatomy or sexual function, even though they cover the penis in detail. The penis has its own article. The penis is covered in detail in male reproductive anatomy, and the penis is covered in detail in literature on male sexual dysfunction. What's really funny is that their experts said that it would not be helpful to cover detailed anatomy of the clitoris in their articles on female sexual dysfunction. But in their articles on male sexual dysfunction, they say it's really important to have an in depth understanding of the anatomy and physiology of the penis. It's just weird. I'm like, why can't they just apply the same logic?
Ah.
It's not different. Like,
Oh my gosh. Yeah, it's okay. I feel like there's a lot of things that are occurring, broadly speaking, where
So there's a lot of resistance to change. Like, I think so, like, one problem is medicine is not very scientific
Mm,
because I think, you know, one of the pillars of science is, the ability to criticize it, having like a tradition of criticism where it can progress with new evidence. Um, and in medicine, people get very attached to whatever they've been taught. There is a lot of status quo bias and a lot of just blind deference to authority.
yeah.
Like a lot of doctors aren't asking, is that true? They're
Mhm.
just memorizing. I think one problem is medical training requires doctors to absorb a lot of information. So they have to memorize a lot.
Mhm.
And so then they may not be stopping to question as much.
Sure.
And I think also it's this grueling process. They devote so many years of their lives to this degree. And I think there's a lot of ego and identity attached to it. So then there's a culture where they really don't like being told that they could be wrong or that they could be doing something wrong.
Mhm. Mhm.
Um,
Oh
yeah,
my.
it's really tricky. I've had a lot of people tell me that it would be easier if I were a doctor myself. And that is the other thing that I would tell myself when I was younger is if I could go back in time, I would tell myself to go to medical school.
Mhm.
But what happened is I talked to my dad towards the end of college and I asked him who changes medicine at scale? Who like I was interested in who changes the training standards, what they're required to learn, what procedures they're allowed to perform. And my dad said not doctors, but that's not right. Like the doctors are actually the one. So what's interesting is how little my dad knew
Yeah.
about how sorry, was that my
It's
computer?
okay. No, no, that was fine. You're fine. You're totally good.
But yeah, what's interesting is how little my dad understood about how medicine is structured and governed and organized, because he thought that doctors don't change medicine, but it's actually a lot harder to change things from the outside.
Mhm.
I think I wish that I had read more books in general, but I wish that I had read Influence by Robert Cialdini because it says you know, doctors have tremendous authority.
Mhm.
So, like, having an MD next to your name, it really helps
Yeah.
with getting listened to. It's actually so extreme because if, like, men say that large labia minora are caused by sex, they get, ripped apart on the internet. You know what I mean? But if doctors say it, people don't question that at all.
Oh,
It's really bizarre. Like, nobody wants to call out a plastic surgeon for saying that protruding labia minora are caused by sexual activity, but they'll call out a teenage boy on Reddit. You know what I mean? It's really interesting how much doctors can get away with because of how much people trust them. That trust is declining,
mhm.
and I think it's declining because of untrustworthy behavior.
Sure.
And because the untrustworthy behavior is more visible in a world where patients have access to medical information.
For
We
sure.
have more independent access.
Yeah. Well, I appreciate all that you've shared today, and I know that this will prove very helpful for all the listeners. Women in my personal life, we've discussed these topics at length many times, and there's actually another woman who's a part of this series who credits you. Her name's Alyssa Sokoloff of Sculpted Femininity. She created one of her pieces of art is the vulva throne. And
Oh,
she's like, yeah, she reached out to me and told me because I think she was calling it the vagina throne. And you had pointed out to her that that was actually incorrect. And she was so grateful that you were willing to say something to her so that she could be correct. So even on something, I don't want to call it simple because her art is not simple and it's actually quite profound and important in my opinion. That shifts the language used for so that we're more anatomically accurate when we're describing various parts of our body. So I want to thank you for impacting her, impacting me, and actually standing in this work. And whatever it is that you do next, I'm positive it'll be in a big and very important way. And before we close out and say bye, I would like to just open the floor for you one last time to share anything that you would like.
Oh, well, I saw Alicia's throne at Burning Man, so that was awesome.
Yeah, 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 yeah. Awesome.
um, yeah, I don't know.
Perfect. Well, how about this? If where can everyone find you and what you're up to?
They can find me on Instagram at Jessica underscore and underscore pin and Jess underscore and underscore pin PIN and just ANN on Twitter and Jessica underscore and underscore pin on TikTok. And then also I have a website. If anyone wants to volunteer with my nonprofit, you can sign up at sheprojectmed.org. I haven't really gotten things organized yet. But yeah, so that's where you can find me.
That's brilliant and beautiful. Well, thank you so much. And yeah, if there's anything else you'd like to share, fantastic. If not, see you next time.
All right. Thank you.
You're welcome. Thank you for witnessing this episode of Her Drive Sovereign, and I invite you to celebrate with us on summer solstice for a retreat for women by women. To learn more, visit her-drive.com/events, and cheers to sovereignty. Love you, ladies.